Welcome to AETCM, the Emergency Medicine channel. Our case is a 30-year-old male who's a resident of Kollam, bank manager by occupation with no previous known co-morbs, presented to ER with the chief complaints of fever and weakness of the bilateral upper and lower limbs. Fever since 3 days and acute onset of weakness of bilateral lower limbs. Patient was apparently asymptomatic 3 days back, after which he developed fever which was low grade intermittent fever with no diurnal variation and not associated any chills and rigors. There were no aggravating factors, but it was relieved through medication. He was taken to a local hospital 2 days back where he was given injection, IM injection. There's no documentation, probably paracetamol, and then he was and since the 2 a.m. in the morning he had sudden onset of weakness of both his bilateral upper and lower limbs. So he thought of going to washroom initially, that he couldn't get up from his bed. So that is when he realized that there's a problem there, and he feels like heaviness and stiffness of the both limbs. And there was no history of any abdominal pain, vomitings, loose stools, or any headache associated with this fever what he had. And there's coming to his personal history, his diet was normal, appetite was normal, sleep was also normal, and bowel and bladder movements were regular. There was no past family history of any neurological symptoms or any CAD history in the family also. So once coming to the when we saw him on examination, patient was conscious, oriented to time, place, and person, is moderately built and nourished, with the pulse rate of 110 per minute, respiratory rate 14, BP of 136/60, temperature was afebrile, and saturation of 98% of room air, and GRBS was 152. Coming to the systemic examination, S1 and S2 were heard.
What is single breath count?
Single breath count we have not done, but basically we do it in if you're suspecting myasthenia gravis.
Not only myasthenia gravis, all muscle weakness you are supposed to document it, because we are documenting current respiratory distress because of the muscle weakness. It is like GCS. You can afterwards you can see whether the patient is improved or deteriorated. So documentation of single breath count is as good as documenting like GCS and other types of scoring system.
Serious examination was S1, S2 was heard. There were no murmurs, no additional sounds, and the respiratory system was within normal levels. Bilateral air entry was there. Normal vesicular breath sounds, parabdominal soft, non-tender, and bowel sounds were present. No evidence of hepatosplenomegaly or abdominal. Coming to CNS, his higher mental function was conscious oriented. His language, memory, and speech was intact. His coming to cranial nerve 2, which are the pupils, which were bilateral and equally reactive to light, which was 2 to 2.5 mm in size. Coming to cranial nerve 3, 4, 6, which helps in the extraocular movements, those are also intact. His extraocular muscles were intact. Cranial nerve 7, there was no facial deviation or facial palsy. There was no decreased sensation over the face, as well as 8, 9, 10, 11, 12, all the cranial nerves were intact. Coming to the motor system, bulk, bilateral, equal in both the upper and lower limbs, and tone, hypotonia was seen in the bilateral. Hypotonia was seen in the bilateral upper limbs more than the lower limbs, as well as coming to the power was reduced in the bilateral upper limbs. It was left and right of the upper limb, it was 3/5. Lower limb in power was even much more, it was 2/5 in bilateral right and left lower limb. And reflexes, we couldn't feel the biceps, triceps, supinator, and the knee jerk were absent. Only thing, we got the ankle reflex, which was marginally 1+. Ankle reflex was there, and plantars were withdrawal, bilateral plantars. There was no cerebellar signs. We couldn't make the patient work, but the dysdiadokinesia and all were negative. There were no signs of any meningeal irritation in the patient. Kernick's, Brudzinski's, no neck rigidity was seen in this patient. Kernick's and Brudzinski's were negative. His sensory system was intact. We can see with bowel and bladder also was intact, as well as we could see his sensory system. There was no 2-point discrimination. That is also intact. Coming to the initial labs of the patient, we did an ABG initially, which showed a pH of 7.366 with a PCO2 of 28, PO2 of 112, and saturation of 98.
pH is?
pH of 7.366. little bit on the lower side, and bicarb of 15.7 and lactate of 1.7. In this VPG, we have seen additional two more electrolytes, which is the potassium, which was on the lower side, which was 1.4, as well as chloride, which is 109, little bit on the higher side when we are compared to normal things. So we have diagnosed it to be have as a normal anionic gap metabolic acidosis, NAGMA. We were
not acidosis,
but 7.3
towards the
acidotic side. We were diagnosed there, and the initial ECG also showed a sinus rhythm with the first degree heart block with a prolonged PR interval as well as a QT interval in this patient. So going back to the history of the patient, we again asked whether he was taking any medications which was prescribed from outside, and we asked for his meal appetite also. Appetite was increased. He said he was having large quantities of rice in the last 3-4 days. So high carbohydrate meal was one of the history given after we have in depth gone through the history of this patient. That was the history given out by the patient itself. Then coming to the initial labs, total counts were around 13,700, which was neutrophilic predominant of 90% and lymphocytes of 7%. Hemoglobin was around 15.6, platelets of 216,000, and RFTs and LFTs of the patient were normal. And then we were keen on knowing about the electrolytes of the patient, the lab values, which came out sodium to be 136, potassium to be 1.5. When in corresponds to potassium, we also looked into magnesium also, because first we have to probably correct magnesium and then go to the potassium. So magnesium was 1.6. So magnesium in this patient was all right. It was not on the lower side.
1.8 is our lab normal value.
1.6 is low. And then the calcium was 8.99 and phosphorus was 1.2. CRP was...
What is the importance of serum magnesium to body magnesium? What is the relevance of this serum magnesium? Is it exactly reflecting your body magnesium? That is a problem. A small deficiency in the serum magnesium can be a huge deficiency in your body, because only 1% of your magnesium is reflected in your lab investigation. So that you have to be very careful.
So in view of the potassium being low, we have further investigated him. We have sent the urine potassium, which is 9.1 millimole per liter, and urine osmolality, which was...
What should be the urine potassium in hypokalemia? What is the importance of urine potassium in hypokalemia cases?
During we take the TTKG, which is the
TTKG, you have to calculate afterwards. But
urine,
if it is urinary loss, it is more than 20. If it is non-urinary loss of potassium shift hypokalemia, it will be normal. So here it is 9 means 9. There is no
urinary loss of potassium.
Okay, either patient is not taking or shift might have happened.
So the urine osmolality came up to 576, whereas the serum osmolality or the blood osmolality is 298. After the initial investigation, we have...
What is urine magnesium? Did you do urine magnesium? Is it important? That is also important, because when potassium is low, there is a high chance of urinary loss of magnesium. So unless until you correct that magnesium level, you cannot correct potassium. Unless until you stop the loss of potassium through the kidney, that is also not be corrected. So everything is interrelated. So better to correct all these things properly. So urine magnesium is important.
In view of the ECG changes, as we have seen, ECG changes in hypokalemia, what we expect is to be the decreased T wave amplitude with the ST depression, followed by the T wave flattening or inversion with the prominent U waves. This is a specific pattern what we have want to see in a hypokalemic patient, but since it was a first degree heart block as well as a prolonged PR and a QT prolongation was there, we have gone ahead with the cardiac enzymes of this patient, which was mildly elevated, CKMB of 6.6 and CK total around 480, the first set, and the remaining next sets were downtrending. Coming back to the thyroid function test of this patient was evaluated because few cases have been noticed, but not primarily in India, but in Japan and as well as China, which thyrotoxicosis was relevant with the hypokalemic periodic paralysis.
Is cranial nerve involvement common in hypothyroidism?
No, sir. Not.
But there are some muscles are there, no?
Muscles are there, but that is extremely rare to find a cranial nerve involvement in this patient. As we check the cranial nerve 2, 3, 4, 6 and all extraocular muscles, everything, and 7 there was no facial deviations. It's extremely rare to see.
Only muscle involved which is related to a cranial nerve is diaphragm. But there it is only controlled by the cranial nerve or the part of cranial nerve.
Break. So the thyroid function test.
Skeletal muscles are mainly involved. Okay.
Coming to thyroid function test, the TSH was very low. It was less than 0.005 with T3 of 6.4. Our normal lab T3 is around 2.7 to 4.3 and T4 is 3.88. Our normal lab is 1 to 1.7.
So
hyperthyroidism in a picture with hypokalemia induced paralysis is we are thinking at this stage. So we start the patient on carbimazole with 10 mg.
You have done
we have done an ultrasound neck for this patient to see the thyroid as well as
thyroid scintigraphy.
Thyroid scintigraphy for this patient. Ultrasound neck shows features suggestive of thyroiditis. So for further evaluation, we sent for a technetium 99 centigraphy scan of the thyroid, which shows increased trapping of function of the thyroid glands with florid Graves' disease kind of picture. They have
throughout the thyroid gland, uptake is very high. That's why we are thinking it's a autoimmune inflammation of the thyroid Graves' disease.
And there was no evidence of cold nodule. Cold nodule basically in malignancy kind of picture we expect. So they documented there's no evidence of any cold nodule for this patient. So
cold or hot nodule? Malignancy produces hot nodule. Hot nodule means only that area traces will be more. Yeah. Other areas will be normal. Cold thyroid with thyroiditis is a feature of viral thyroiditis. Cold thyroid means there is no active uptake, but patient is having thyroiditis. That is a feature of viral thyroiditis. So here active uptake is more and thyroid function test shows hyperthyroidism. That's why we think it is Graves' disease. And this hypokalemic periodic paralysis is common with Graves' disease.
Yeah, thyrotoxicosis is common. Basically, it is thyrotoxicosis primarily is a feature of women, means it is predominantly seen in women, but in young males with thyrotoxicosis, there is a chance of hypokalemia also in the patient. So after that, we did an NCV study just to rule out any underlying neurological things. That showed this a normal study. There was no evidence of pathology affecting the motor neurons, muscles of the upper and lower limb, but not any significant changes with that. So with this, we have come to a diagnosis that the patient presented a 30-year-old male who presented with a history of 2 days history of fever with acute onset of weakness of bilateral lower and upper and lower limbs. And when we started evaluating, his potassium was on low side, so hypokalemia. Presented with further investigation, we did a thyroid test which showed thyrotoxicosis. So thyrotoxicosis with hypokalemic periodic paralysis would fit into our diagnosis.
What is happening to the potassium here?
Intracellular shift of potassium, because we have again documented the renal loss. And
what are the reasons for such shift?
High carbohydrate diet is one particular reason.
Important reason is high carbohydrate diet. Right. Then
if he is diabetic and using any insulins, that
insulins can produce. Then
catecholamines can cause.
Catecholamine release, acute release of catecholamine. Here in hyperthyroidism, one of the reason for that is increased release of catecholamines, hypertension, all these things. So one of the reasons.
Hormone also.
And he had fever. That is another reason for shift. Infections. Okay, so in a patient who is having hyperthyroidism, infections and increased catecholamine release, all these things might have contributed to develop this periodic paralysis
of the patient. So then we went into management of the patient. So initially we have started with potassium, IV potassium correction.
So initially you'll have only one peripheral line. What do you do?
We basically see for an EJV or a central line.
Initially you know that patient is having bilateral weakness, patient is having all limbs are weak, anytime he can develop respiratory paralysis, arrhythmias can occur. Normally we put a peripheral line. So what do you do now? We can put central line, it takes some time.
Yes.
So you have a peripheral line now. What do you do now?
20 milliequivalents.
You have to immediately start the treatment because we cannot wait for a central line to put that expert may not be there. So immediately start the treatment. Only problem it can produce is maximum. It can produce thrombophlebitis in the peripheral lines, but we have no other choice. We have to start the treatment immediately. One ampule contains how much potassium? KCl? 20 milligrams. One ampule contains 20 milligrams of this one. You can add one ampule to normal saline or dextrose.
Normal saline.
It has to be added only to normal saline, not to dextrose. That can be immediately started to the peripheral line. Then by the time you can try for a central line. Okay. And what is the total requirement of this patient? This patient's potassium is 1.5. So what will be the total requirement to correct potassium to a level of 3.5? So that is very important. Okay, so one deficiency from the normal, that is 3.5 to this one is, so he is having deficiency of 2 milliequivalents. So it will become 600 milliequivalents is total deficiency. Okay, whereas magnesium we cannot even know what is a deficiency. It is low, so it may be very high. We don't know what may be the deficiency. Here potassium deficiency alone is 600 milliequivalents. Okay, that much you have to give over 24 hours. Okay, so that for that you need a central line. Okay, each ampule contains 20 milligrams of potassium chloride. Okay, now during the transfusion, what all things you have to monitor the patient. So we are giving around 600 or maybe 400 or 500 in a day. In a day we are giving to the patient. What all things you monitor? Is it dangerous or not dangerous? Or
while giving potassium also we have to monitor the ECG of the patient. So he has to be connected to a monitor, cardiac monitor, because arrhythmias, both hypokalemia as well as hyper.
Is there a chance for hyperkalemia in this patient?
Yes, because
why? So while treating, suddenly the potassium which has shifted to the cell can suddenly even come back to your circulation. And you are giving high potassium. So these patients can sometimes produce hyperkalemic attacks, but only advantage is when the kidneys are normal, it may not happen. Kidney will try to remove it. Okay, so that is only advantage since kidneys are normal. But there is a chance for rebound hyperkalemia that you have to be very careful. Okay, then so potassium is given like that. How much time it took to correct the potassium?
For us it took like 10 to 12 hours. By evening, when the patient was checking, it was back to normal.
How many times you have to do the potassium during that period?
2.
Every 3 to 4 hours, you have to do at least once, see the potassium, whether it is getting corrected or not. Okay, sometimes initial lab value can be wrong. So we have to be very careful while correcting the potassium levels. Okay, then. So during correction, what will you look in the monitor? Tall TVs may not be visible in the monitor. What is the most important? Bradycardia. Bradycardia will be the most important thing. Okay, but we have started propranolol for this patient, so bradycardia may be a part of that treatment itself. Then how did you treat that hyperthyroidism?
Hyperthyroidism, we gave him carbimazole, 10 mg TID, as well as he had few symptoms of these palpitations and all to control that, which is secondary to hyperthyroidism. We gave him propranolol, sustained release 40 mg BD. Okay. Kept the patient.
So propranolol also started. That can control the heart rate, and peripheral conversion also can be reduced. Okay. So propylthiouracil 10 milligram may not be sufficient. We'll have to increase to 20 milligram TID. And propranolol can be continued. Is propranolol can do anything with the potassium?
Beta blocker in that.
Beta blockers are just opposite of alpha blockers. Beta receptors. When the beta is overstimulated, potassium can. Okay, so just opposite can occur. Okay, so that also we have to be very careful when we are giving beta blocker. Opposite effect can occur, but not in this dose. Okay, but what is the dose we are giving in this patient? 40 milligram SRBD. Okay, so that is also very important. Beta blockers like propranolol act only for 6 hours. So if you want to give a sustained action, you have to give SR preparation. Okay, so that is also very careful. Okay. Now, what happened to this patient afterwards?
We have still, he's like 2 days back he admitted. We were continuous potassium monitoring was done. Right now his paralysis and all his power has been regrouped. He has improved a lot. So we are just managing him as of now.
Okay. So it's a hyperthyroid Graves disease, hypokalemic periodic paralysis. Is it come under channelopathies?
Yes, it is basically a calcium channel disease in the body. It is basically autosomal dominant in inheritance, and mostly male to female predominance is 3:1.
Okay, male it is very common.
Male it is very common, and due to a mutation in the region containing the alpha subunit of the calcium channel, that is CACNA1S.
Okay.
As well as very and another sodium channel is also there, which is SCN4A. That is also like very 8 to 10% is there, but major of the cases 90 to 90% will have this mutation of CACNA1S channel.
Okay. So what is the treatment for this type of problems? This is common in children, but adult also it can present sometimes.
Yes.
Okay, it can be aggravated by your high carbohydrate diet, your infections, hyperthyroidism, all these things. Here it may be due to increased tachycardia and adrenergic overdrive, or maybe due to the infection. So what advice you can give? So anytime it can come back. Once you develop hypokalemic periodic paralysis, again you can develop the same problem.
So
what advice?
We should avoid, ask him to avoid strenuous exercise primarily, and take a carbohydrate low carbohydrate diet.
Okay.
More of proteins in the nutrition, and now he's been thyrotoxicosis to measure his levels of thyroid hormones after every 3 to 4 months.
This propel Thyroxil, how long you have to continue?
We should.
Since you are in medicine, I am asking this question. For emergency medicine, it is not required. So how long you have to continue?
After 1 month, we have to recheck.
So normally this treatment has to be given for at least 2 years.
2 years.
And during that period, you can get different scenarios. Sometimes what will happen, the patient will go to hypothyroidism.
Yeah.
Okay, so you have to give a different strategy. You have to give propel Thyroxil, and sometimes you will have to replace the thyroid hormone also. So together, so you are giving something to block the thyroid hormone production, so the patient may completely go to hypothyroid state. You will not be able to stop the drug, because once you stop, again the patient develops hyperthyroid. So in that case, you have to support the patient with a smaller dose of thyroid hormone. Okay. So during the treatment, you will face a lot of issues. Okay. There is another drug, carbamazole. Here we are giving propel Thyroxil. Carbamazole, when you are giving, what all precautions you have to take?
Agranulocytosis
can occur. Is it safe in pregnancy?
No, only propel Thyroxil is a drug of choice in pregnancy.
So propel Thyroxil and carbamazole both are very good drugs. This has got some advantage that it will not much side effects are not there, and pregnancy can be given. Here in this patient we can give both the drug, carbamazole or propel Thyroxil. Both are equally effective. Steroids, any role in this patient?
As of now, we have not.
As of now, there is no major role. We know that it is an immune-mediated disease, but in hyperthyroid Graves disease, it has got no major role. Suppose the patient is having pain, swelling, there it may be slightly effective to relieve the symptoms. Otherwise, it is not required. Any other treatment options, add-on drugs are available for this hyperthyroidism other than this? Cholestyramine. Cholestyramine also can be given as an add-on drug to your regular therapy. Okay. So that also can be done. Magnesium should be correct in this patient?
Yes.
It is a must. All hypokalemic cases, whether it is shift or urinary loss, magnesium has to be corrected, because the problem can be aggravated with 2 electrolyte imbalance. Other one, potassium will never get corrected without magnesium correction. So that we have to take care. Anything else you want to add? Okay. Thank you.
Thank you.